Now we will move to Professor Savage, who will talk to us on the clinical skills that are essential for the accurate diagnosis of short stature. Thank you. Could we have Professor Savage's slides, please? Just to remind everyone, the questions will be answered at the end. Please put those in the Q&A box at the bottom. Thank you, Professor Savage.
Thank you, Justin. And it's a pleasure to be with you all today. I'm going to talk about clinical skills being essential for the accurate diagnosis of short stature. My disclosure. Learning objectives. At the end of this presentation, you will basically understand which clinical skills are important for accurate diagnosis of short stature, appreciate the importance of these clinical skills, such as history taking, physical examination, and evaluate the role of AI, particularly related to genetic sequencing, for example, which has a place in the diagnostic protocol. So basically, a very brief classification of growth disorders, and then looking at the different aspects of clinical assessment, history taking, establishing the doctor-patient relationship, and really gauging the quality of that relationship through encouragement and commitment on the part of the individuals involved, and preserving clinical skills. So here is the now, I think, accepted classification of growth disorders. Basically, primary growth disorders are shown here. These are defects within the growth plate. Secondary growth disorders are defects outside the growth plate, but which influence its function, as you see here. And then thirdly, a group of idiopathic causes. And here is the classification. I won't read this through. You can see it on the website. But the main thing to realize is that the etiology of short stature is very broad. As you can see, the possible categories at the top, and the approach to the child should basically be as a general pediatrician or physician and not as an endocrinologist. For example, we may be dealing with a completely normal child. Normal children do not need specialists. The diagnostic approach to short stature is more an art than a science. It's important to look at the patient rather than the computer screen. And don't forget, you're a doctor, not a technician. So we start by taking the history. This is extremely important, and this is a clinical skill which has to be learnt and practiced. The key points are you need to take some time, you need to listen, you need to ask questions carefully, and be attentive. And these are some of the areas which need to be probed and questioned. Let's look at an individual case. A 14-year-old boy comes to the clinic complaining of short stature and delayed puberty. You can see he's a healthy-looking child here, and he does have delayed puberty for his age. Okay, now, if you went through the history taking very rapidly, as I suggest an AI program might do, and simply involved ticking boxes, for example, no respiratory symptoms, no gastrointestinal symptoms, no urinary symptoms, etc., you probably come to the conclusion that this child almost certainly has constitutional delay of growth and puberty. Well, if that diagnosis was made, he would be given testosterone, maybe monthly for 3 months, and then seen again to look at his response. At his next consultation, his growth velocity had hardly increased at all, and he was still upset and lacking in confidence. And the parents were disappointed with the response. Why has he responded poorly? Because the diagnosis is wrong. It's incorrect. He does not have constitutional delay of growth and puberty. So let's look again at what should have been done. Does he have any gastrointestinal symptoms? No. But you don't move on then to the other systems. You probe and you ask direct questions. And this is a clinical skill. Is his appetite good? Yes. Does he have abdominal pain? No. How many times does he have his bowels open a day? 2 to 3 times. Now you think to yourself, that doesn't sound quite normal to me. Then what makes him go to the toilet? Oh, after a meal. Immediately after a meal, he rushes to the toilet, and that happens several times a day. You think to yourself, this is not normal or usual. He basically needs further investigations. So we do further investigations, and he has a full blood count, which shows that he is borderline anemic. He has a slightly elevated ESR, and he has a celiac screening test, which is positive. And then he has a jejunal biopsy, which is positive for celiac disease. And then he started on a gluten-free diet, and he grows. So basically, he has celiac disease, and this diagnosis was missed initially because we did not ask direct questions when taking the history. Let's move on. Physical examination. These are the key features here, but the last one is very important. Document dysmorphic features. Clinicians have to learn to be skilled observers. Now, we can all do this. We can all learn how to look at the child critically and observe the details. For example, let's look at this syndrome. Now, I would be very interested to ask Paul Dimitri whether his facial recognition program is based on the identification of the absolute typical features of this syndrome or the mild features. Would AI have picked up the fact that this boy has an abnormal face? It's very subtle, but he has an abnormal face because he has widely spaced eyes and low ears, but he doesn't have the ptosis, and he doesn't have the antimongoloid slant of the eyes. And so the question is, would AI have the sensitivity to make the diagnosis in mild cases? Of course, this is Noonan syndrome, as you will all recognize. And this is where the clinician needs to be very observant and look for signs such as the protuberant abdomen in celiac disease, the wasting and the malnutrition associated with Crohn's disease, the disproportion associated with skeletal dysplasia, and the often very mild dysmorphic features of Turner syndrome. This is where clinical skills are very important. And we can all develop these clinical skills. It's simply a question of learning how to look at the patient and not the computer. So then you come to general investigations. Now, in 2008, we published a recommendation for performing these tests, these general pediatric tests in children with short stature. But this was formally challenged in this publication from Dr. Sisley in Cincinnati. And she looked at a number of children, and they all coming to the pediatric endocrine service, and they all had the tests. And she said that 98.7% of these children did not have any abnormal tests. So she concluded that the classical approach, in other words, screening for general pediatric disorders, was wrong, and that screening tests were not cost-effective in healthy short children. Now, it's very important to be aware of publications like this because they can be used to actually eliminate screening tests from the protocol. And in my view, that's a great mistake. So screening tests are very important. Finally, what about genetic tests? Well, again, there's been a challenge to our classical approach of clinical observation, history taking, etc. And it's been said that standard medical evaluation rarely leads to a diagnosis in a child with isolated short stature, and that basically this should be replaced by genetic testing as the primary diagnostic modality in children who do not manifest clinical abnormalities or signs of hormonal deficiency. I would challenge this statement because I think the standard medical evaluation is useful, and but we have to recognize the value of genetic sequencing in some situations. And this is where AI and digital tools are of extreme importance because, for example, these are the red flags for looking at genetic sequencing in children with short stature. Parental consanguinity, severe phenotype, single affected parents, family history of affected siblings, a recognizable phenotype and endocrine features, and severe multisystem features of unknown cause. And this is what this child had. Clearly, she is not normal in her appearance. But we just couldn't put it together. We couldn't fit it together with a known syndrome. So we performed whole exome sequencing involving sequencing of the exons, and we found that there was a mutation, a homozygous mutation in the exon of the gene consistent with Bloom syndrome. Now, this is just an example of how whole exome sequencing is important. Now, finally, I'm just going to pick out some features if we look at AI and clinical skills, the comparison. As Paul said, AI should be considered as a complementary tool rather than a replacement for healthcare professionals. Clinical skills and expertise may vary from center to center, and that's why we need to go back to rely on our basic clinical protocol of assessment. And for example, if you have an unexpected issue, as we found in the boy with delayed puberty, because we we moved sideways. We thought laterally and picked up the fact that he was going to the toilet 3 to 4 times a day. That was an unexpected finding. And can AI deal with that sort of unexpected finding in its program? Secondly, it's important to realize that children have individual needs and vulnerabilities. The core value of clinical care needs to remain at the heart of the relationship between the healthcare the professional and the patient. And AI cannot create the doctor-patient relationship or test the strength or weakness of that relationship. The physician has to make eye contact with the child and the family in order to gain their trust and to show his or her commitment to caring for the child. AI can't do that. The skill of history taking with asking direct questions is again something that comes much more naturally to humans than to machines. However, what AI can do is by cutting corners, it can save us time, and it can provide the gift of time, which creates opportunities for clinicians to focus on compassion and empathy. And finally, if you go to a clinic which is disorganized, AI will not pick that up. And I think it's terribly important that that the lack of leadership and organization in a clinic leads to poor adherence and poor patient care. So basically, AI can recognize patterns, but it cannot gauge emotions or instincts or psychological variants in human emotions, such as doubt, fear, suspicion, or confidence. In conclusion, maintain clinical skills, history taking, examination and observation, establishing the doctor-patient relationship, gauging emotions, assessing the quality of healthcare professional leadership, and establishing eye contact with the patient and family for encouragement and reassurance. We are doctors, not technicians. Thank you very much.